topic which is itself is something which is different and new. So let me ask you, most of you must have faced difficult airway in your practice, right, in the past. So now when you, in the hindsight, when you think about it, do you feel that difficulty may have been different now? You may have a different gadget, more experience, or maybe it could have been handled differently by someone else. That means the difficulty is different for everyone. In fact, in my opinion, difficult airway does not exist. Now, this is a very bold statement for a general secretary of All India Difficult Airway Association. We are actually a difficult airway association, and we say difficult airway does not exist. Why? Because it is not my opinion. This is very well described in this particular article by Hans Huitink. Why we say that it does not exist? Because it is context sensitive. That means it could be a difficult for someone, reduced mouth opening to an anesthesiologist who does not have access to all this equipment would be a difficult airway versus similar for a cancer anesthesiologist who gives anesthesia in a cancer patients routinely deals with awake tracheal intubation, and then it is very easy for them. So it is a context sensitive. And also there is term difficult airways, there is a lot of confusion. Now, what are the causes of confusion? Why there is a confusion? Because it is not very well defined and documented. There are different ways and same airway can be managed. Predictions models are not very sensitive and specific, so we are not able to know which patient is going to be difficult. And we evaluate only anatomical difficulty, but other factors are not taken into consideration. Let us go into slightly more detail of, this confusion. So when you look at the the latest guideline on difficult airway published by ASA, American Society of Anesthesiologists in 2022. So that's a definition. A difficult airway includes the clinical situation in anticipated. So we know about it. Now, if you take a closer look at this particular sentence, experienced by a physician trained in anesthesia care. So by definition, difficult airway can only be termed after failure. After you experience the difficulty, then only you can term that it is a difficult airway. And by physician trained in anesthesia care, what about the other doctors, those who have to take a airway challenge? Intensivist, pulmonologists, physicians, medical officer, emergency department. There are so many persons other than anesthesiologists who are actually doing anesthesia care, intubation management. What about them? Will it be difficult airway for them? Next thing, history of previous difficulty is one of the most important consideration for the prediction of difficult airway, right? If you have a history of previous difficulty, then it is, you are more likely to face difficulty and you have to be really alert for that. Tell me, how many of you actually document if you have a difficult airway in detail and give that handout to your patients, mentioning actually what happened? Okay, even if you are doing it, the documentation is not standardized. So when you say, I have a face mask ventilation difficulty, there are 4 grades and we don't mention those grades. And the grades are also different by a different authors. So someone say, okay, putting an oral airway or an nasopharyngeal airway is grade 2 difficulty, but someone will say, okay, if I need 2% technique, it could be a grade 2 difficulty. So when we mention, it is actually not standardized. So often ignored, we don't do it well. And many times it is not standardized. So the next person doesn't know actually what is actually happening. On top of that, if you ask 2 anesthesiologists to do laryngoscopy on same person and ask them to grade the laryngoscopy for Cormack-Liana, most of the time there will be a difference in some Cormack-Liana grading or a Pogo scoring. If someone say I can see 75%, other person which I can see 60% or 80%. So there's an inter-observer variability. We use similar grading for video laryngoscope where it is actually unintended use. Cormack-Liana cannot be used because most of the time grade is 1 or 2 only. The Pogo scoring is a better, scoring for video laryngoscopy, but we still use Cormack-Liana. So if input data are incorrect because of improper documentation or imprecise scoring system, the prediction which we do would be unreliable. Now, there are many ways you can manage the same airway. Let us look at some examples. Pre-oxygenation. between two anesthesiologists, they will pre-oxygenate for a different duration. The FiO2 will be different. The fresh gas flow will be different. Someone will do it with closed circuit. Someone will do it with open circuit. Or ICU patients, you may have a CPAP, NIV, high flow nasal oxygen. For the induction of anesthesia, there are multiple choices, the different drugs, IV versus inhalation. You can do awake versus asleep induction. So there are many ways a same patient can be induced. Bag and mask ventilation, again, there is different type of mask, different type of grip. So all these different choices can make difference in the outcome. Someone, for a senior person who is very expert in bag and mask ventilation, can do some patients very easily, while a novice very difficult, or a resident may find it difficult to ventilate a patient. On similar line, laryngoscopy, there are 20 plus laryngoscope blade, 20 plus video laryngoscopes of different variety, which has a different outcome. Similarly, even for endotracheal tube, when you do awake fiber optic intubation, your success rate is different with different type of video endotracheal tube. A PVC tube, you have a lesser chances or more chances of a problem versus wire reinforced special tip endotracheal tube, which has a better chance of success. Supraglottic airway has the widest choice. 80 intubation 8. There are different type of style, shape, rigidness, material. You can oxygenate through it. You have a different type of steel. So for supraglottic airway, there are 80 types of supraglottic airway. For awake intubation, there are, many methods. You can do it from the front, you can do it from the back, you can do it from the nasally, you can do it from the orally, you can use video laryngoscope, you can use sedation. Everyone will have different implication and the success rate. Similarly, for the even surgical airway, there are multiple options. So a same airway can be managed by a different anesthesiologist in a different way and still come out successfully. So it is very difficult to say that, okay, I have failed because this, I have failed because this was a difficult area. Someone else, it can be very easy if you use a different technique. Then prediction. We always know that if we can predict, we can plan better. But we are not good at predicting. This Danish database, which has 188,000 plus cases, there are difficult intubation in 3,391 cases. 93% of them were unanticipated. And when they anticipated difficulty, only 25% of that were difficult. Similar for the face mask ventilation, 94% unanticipated and only 22% they could anticipate. For predicting difficult airway, we use airway assessment. We do some criteria, but we know that prediction is not very sensitive. They are not very sensitive. So prediction itself is unpredictable. And on top of that, we are not able to take the other factor or a non-patient related factor into consideration. What could be these non-patient related factors? Experience of the anesthesiologist, time pressure, middle of night surgery, evening surgery, when you are actually tired, you know that, okay, fiber optic or a flexible endoscope or a video bronchoscopy is the ideal technique, but not available. You are in some hospital where actually you are, away from your main hospital, you are in a remote location and you don't know how to do it. In the sense, you don't have those equipment, or you are in an ambulance where airway management would be more difficult. And then, so a class 1 airway for a planned surgery would be easy for anesthesiologists in operation theater, but similar patient or airway becomes difficult if you are doing it in ICU by an intensivist in middle of night. So your perspective changes with the different location, different person at different time. Similar example, a class 4 airway, Malampatti class 4, a restricted mouth opening in a Tata hospital is a very easy airway. They do awake tracheal intubation with video bronchoscope every day, and it is not a difficult airway for them. Would be a difficult airway in Aurangabad for an anesthesiologist working in a private hospital. And then the human factors, which is actually not emphasized enough in our training. When you go in crisis, when you have unanticipated difficult airway, who will become leader, who will follow the instruction? You have to remain aware about the situation, time passage. You need to make critical decisions, shift from one technique to other technique, and then communications. These are the things which are actually not emphasized enough when we are learning the airway management or when we think about a difficult airway. So you have to take this factor also into consideration. So now we know that what are the difficulties, what is the point of confusion. So how to incorporate this factor into airway assessment to make it better. So far, we are only focusing on the anatomical aspect of the airway, and we look at mouth opening or a malampatti or neck movement, and then we decided difficulty. But we have to consider so many factors. So now, how to go forward from this? So to incorporate this, we have to consider two things. One is airway factors, and second is non-patient related factors. This Hans Huitink actually termed this as airway factor. He divided them into two, basic airway and advanced airway. And for non-patient related, it is a complexity factor. So these are two things which you have to consider. Now let us look at the airway factors. Now our airway journey is often flight journey from takeoff to landing, from intubation to extubation. And the cockpit is often compared with our airway anesthesia workstation and the anesthesia system. Both systems are undeniably complex and having many human and technical elements interacting with. Now, for the flight journey and cockpit, there is a checklist which is used by crew to make sure that aircraft is in proper configuration for entire course, takeoff and landing and everything. While for the anesthesia, we rely on only our memory. Okay, we ask in morning that, okay, is this anesthesia, if you have advanced system, you do that testing, is it okay? You ask them, or sometimes you do it on your own. But then for other things, there is no checklist. If it is there, it is not standardized. Like for cockpit, every flight journey, there is a very similar, absolutely same checklist. Every time it is followed, same checklist is followed. Here it is not standardized. Every hospital, every individual, he will have a different checklist. So our structured and disciplined approach is lacking. If we have that, then we can prevent many unanticipated events. And if it occurs, there are guidelines which can guide us to, come out of that particular situation. So what could be our airway checklist? Okay. Airway checklist should cover many more factors than the anatomical factor. Patient factor, history, airway assessment, surgical procedure we have to consider, and evaluation of vital signs. So this is being called by Hans Huitink as a phase checklist. Okay, this is a phase checklist. So what are the components of phase checklist? Like patient factors, ASA status, age, comorbidity, BMI, so patient's dimensions. Then history of previous airway complications, reconstructive surgery, radiotherapy, and so on. Airway, this is something which we are actually doing it regularly. Malampatti, no loose teeth, neck movement, short neck, active bleeding, stridor. Then surgical procedure, whether it is in the neck or in the airway region or it is outside airway region. And then whether patient is stable vitally, or will maintain stability in their patient's own vital sign while we are anesthetizing. So this could be phase checklist. And phase checklist can give you idea about whether this would be a basic airway or an advanced airway. This is one terminology which is used by Hans Huitink. This is good. But you can always develop your own terminology, or we may come out in future with slightly different. But on the basis, right now, we can consider it as a basic airway and advanced airway. If any of this phase checklist is abnormal, we should consider it that there is a difficulty and we can consider it as an advanced airway. Now, the non-patient related factors. Now, this is very well explained by Hans Huitink as a complexity factor. Now, what is a complexity factor? It is actually, complexity theory is described with actually words. It uses a scientific principle to model and explain the system. And there are 4 elements into the adaptability, interdependence, interconnectedness, and diversity. Just take an example for airway management. A patient in ICU with obesity and COPD in respiratory distress needs intubation. Now, here an intensivist or the anesthesiologist needs to adapt himself to the ICU situation. For obesity, he may have to use different device, technique, or oxygenation, which he is not routinely doing. So you need to adapt. You are dependent on intensivist and nursing staff. So there is an interdependence, there is interconnectedness, and everyone is independent. Like an intensivist will help you in identifying the oxygenation or a ventilation part, or a nurse will prepare the equipments, help you in, guide you and help you and monitor the patient. So there is adaptability, interdependence, interconnectedness, and diversity. All 4 different people and a different situation you are. So advanced airway management is a very complex factor, and complexity factors can apply here. So what could be this complexity factor in airway management? The human factor. There is a language barrier. A Maharashtrian or a South Indian patient coming to your operation theater in confusion is going to speak his or her own language. They are not going to speak in English, which otherwise they are doing. You are fatigued, you are in under stress, will affect your outcome. Lack of skill, experience. You know, flexible awake intubation is actually needed, but you don't have skill for that. Or you are in a remote hospital, or you are in a CT scan center, or an MRI, or in an ambulance, or a remote hospital. We already know that there is a prior radiation therapy actually makes it very, very difficult. Technical problems, your equipment, you know you have an equipment, but it's not working. Or there are unstable vital signs, which gives us time pressure. We don't have enough time. So these are the factors which he again described as a help ET checklist. Okay. So complexity factor can be identified as help ET checklist. So you can make a help ET checklist, which gives you which, if there are abnormal factors, which makes it advanced, and if it is multiple, then it makes it more complex. And we can call it by, as he has described as, highly complex, low complexity can be identified. So you know that, okay, with this complexity factor, you know that you will require more help. Okay, let us take an example. Now, this is help. So hour, that means time. Let's say it is morning hours. You are an experienced anesthesiologist. It is done in location, that means it is in operation theater. Appendicitis, that's the procedure. You have a video laryngoscope available and vital signs are stable. So this is absolutely normal. This is basic airway. There's no complexity factor. This can be very easily managed by routine anesthesiologists, or any anesthesiologist who is trained can be managed by very easily. But let us look at the similar patient in a different situation. Now patient has some airway factors. He has bhakti and malampatti. So this becomes a slightly more complex. But the complexity is only in one domain, that is in the patient. All other domains are normal. So this can be considered as a low complex, but advanced airway. There is slight difficulty. So in this situation, if you are an experienced anesthesiologist and you have a device which you feel the best device, then you can proceed. But if you are a junior anesthesiologist or a resident, then you should call for help. You should have a backup ready, or you should go for the equipment which is, if it is not available, you have to make efforts to make it more, available. Now, slightly different situation. A junior resident in middle of night, a perforated appendicitis in sepsis, no video laryngoscope available, saturation is falling, is highly complex airway. There are multiple factors in multiple domains. So you should not go ahead on your own. Here, you should definitely get for qualified help, prepare yourself, then only you should proceed. Even for a very experienced anesthesiologist. But again, if there are problems in multiple domains, you are in ambulance, there is a bleeding in airway, video laryngoscope won't work here, saturation is falling. This is again high complex advanced airway. There, even if you are experienced, you should get help, because there are likely chances that things can go wrong, and you may require definite help to overcome this area. So decision making can be based on phase or complexity factor. It could be basic or advanced airway. Basic airway means there is no phase is normal and there is no complexity factor. In those situations, basic airway can be managed by basic airway management techniques like supraglottic airway, mask, or intubation by a trained person. And in unlikely event, there is a airway rescue is probably easily possible. But if there is any of abnormality in this phase or complexity factor, we can term it as an advanced airway. Now, there are three things different than the basic airway. One, you require technique that is not often used. You may need to use awake tracheal intubation, fiber optic bronchoscope, or a video laryngoscope, or high flow nasal oxygen technique. This would require a specialist or a team which has a special skill and access to special airway, and you need assistance. You cannot do it alone. So if there is a complexity factor, you need assistance. Now, problem of this would be that there are a lot of checklists. There are a lot of things to be considered, and we often tend to ignore or forget. For that, a balancing numerous factor will challenge our memory recall. So there is a app which is there, which is called Airway Triage app, which is developed again by same Dr. Hans Huitink. Again, I would like to emphasize that there is no conflict of interest. I also paid, but I really like this particular concept and the app which he has developed. We'll go slightly in more detail how app works. So when you go to the home page, there is checklist which is given. So phase checklist, they walk you through. You have to identify those factors, which are the factors like airway, patient, and then they term it, okay, this is a basic airway procedure. So it will give you idea that, okay, this is a basic airway. Then it takes you through the complexity factors and then actually gives you a scoring of complexity that, okay, it is in one domain or it is in a multiple domain and how many factors are there. And then it gives you idea that, okay, you can choose the device which you are likely to use and then complexity factors. Now, from here, there is an additional thing which is given, which is also very interesting, which is the decision-making checklist. Okay. So once you have gone through it, they again take you through the circle of life. The concept is called the circle of life. Okay. So with this educational model, there is a structured approach and a decision support. So it asks you that, okay, are you ready with this? Are you ready with this? Are you ready with this? Then if it is yes, then you are fit to fly the airway. So what are the components of the circle of life? Assessment, training, gold standard, technique, and so on. Assessment, we have already gone through. Phase and health PT checklist. It will identify basic or advanced airway, whether it is a low complex or high complex, and do you need help or not. Next is they'll ask you to identify the gold standard technique. Okay. Do you have technique and device which is the best technique for this particular patient? And if it doesn't work, do you have plan B? So that will prepare you that, okay, a video laryngoscope or a direct laryngoscopy I can do, but if it fails, I'll use video laryngoscope. Both devices are ready. And you think that you need to use video laryngoscope. Are you trained for that? Do you have clinical experience and the device ready with you? So that will ask you that, okay, are you ready with that? Are you ready to deal with the complication? I know that complication can occur and I can handle this complication. So this every factor, there are two consideration. And once you okay that, okay, I am ready for both the consideration of this particular thing, you are ready to go ahead. Then oxygenation. It asks you whether are you ready and you know how to oxygenate this patient. And I have a second oxygenation technique also. That means you are ready for two oxygenation technique in this particular patient. And airway rescue. That means I'm ready with airway rescue. If what technique you will rescue your patient if the things does not work out, and then is there any other technique? So it takes you through this particular concept of circle of life, and then gives you an idea also that what are the factors which you are not comfortable, like complications you are not sure, so you need assistance. Gold standard technique is video laryngoscope, but I don't have video laryngoscope. So they'll tell you, ask for the help. So if you have skill, experience, device for all the circle, you are fit to fly. Okay. If you have incomplete circle, more help is needed in those particular directions. In fact, once you go through this and all circles are green, once all circles are green, they ask you to take you through the, all circles are green and now you are ready for the procedure. So there is a very interesting concept which is recently introduced called the airway timeout. So airway timeout actually, takes you through it's an audio guided, help.
1. Positioning optimized. 2. Suction ready.
So everything is
Ventable CO2 ready.
So basically it takes you to, final procedure. And there it gives you an idea that, okay, are you ready? You are fit to fly. You are ready with everything. Please go ahead. And then you can also, there is option of recording. So with this understanding, to sum up, difficult airway has many variables. Okay. Only assessment of anatomical feature is unreliable and not help you every time. Many times things are unpredictable in spite of doing airway assessment. So you need comprehensive airway assessment, which includes everything: surgical procedure, history, physiology. So you need to develop a checklist. Non-patient related factors should be taken into consideration. with the help of this called something called HELP PT checklist. So it gives you an idea about basic and advanced airway and the complexity factor. So how much help and assistance you need for one particular case and what techniques you need to consider. And then a decision-making tool will help you to go through each and every aspect in detail so you don't forget anything. So that's the concept, a basic and advanced airway. Now, this could be slightly different also. You can term it as accessible or non-accessible airway. You can develop your own checklist also. But you have to consider all these factors into consideration when you develop your checklist. This is one checklist developed by an author, which is good, but you can always develop your own checklist. It's not that you have to follow one checklist only. You can develop your own checklist, but you have to take all these things into consideration and then identify ease or difficulty or a basic or advanced airway, and then other factors should also be taken into consideration. Thank you so much for your patient hearing. Thank you.